Welcome to podcast 11.
I'm Fran.
And I'm Minnie.
And as always, we'd really appreciate your feedback on this topic and future topics. And please do use the new scoring system, which has just been put up on the forum. So today's topic is preeclampsia.
Thanks, Fran. And the tip for today's topic is to remember to ask your patients about medical problems in their previous pregnancies to allow for possible prevention and early detection of preeclampsia.
Brilliant, thank you. So, as per normal, we're doing a case study. So, Emma is a 28-year-old who is 34 weeks pregnant and comes to a health centre for her routine antenatal check. She had preeclampsia in a previous pregnancy, which resulted in a premature delivery at 35 weeks. She's not overweight and her blood pressure has been normal, as has the rest of her antenatal appointments in this pregnancy. So she comes to see you for a routine check, but does comment that she's had some worsening swelling of her ankles and some abdominal pain. So when you examine her, you notice that she does in fact have some ankle edema. Her blood pressure is 162 over 102. You dip her urine, which has 2 pluses of urine. On measuring the fundal height, she's only measuring 30 centimetres. So we said she was 34 weeks, so that's 4 centimetres under. But you auscultate the heart and the fetal heart rate sounds normal.
Great. So, Fran, would you just do the one blood pressure on this particular patient, or would you let her sit a while and repeat it, or will you be happy to say, right, this is definitely raised blood pressure because of the protein in the urine, or what
so always with anyone with raised blood pressure, I'll do it 3 times.
Okay.
Just to see, because it may be that she just rushed to her appointment because she was late, or that she has what we call white coat hypertension, where she sees a clinician and immediately it makes her blood pressure go up.
Okay.
A bit like mine does, yeah.
Just doing a podcast.
Yeah.
Right. Okay, so let's now talk about preeclampsia. So what is preeclampsia? So this is defined as pregnancy-induced hypertension, so blood pressure greater than 140 over 90 millimetres of mercury in the second half of pregnancy, so post 20 weeks. And it's the hypertension in association with proteinuria, and that would be greater than or the 1 plus of protein on the dipstick or more. Or you can do a 24-hour collection, and this would be if you had more than 0.3 grams in that 24 hours, with or without peripheral edema.
Yeah, so just to say, Minnie, I would not be doing a 24-hour collection of...
It's a bit onerous, isn't it?
No, it's just not something that you do in primary care. You know, if I'm only using dipsticks and if they have proteinuria, then, you know, and I think it's preeclampsia, then I'm sending them up. So, so I don't, just to, you know, just so that the clinical officers listening don't think that I'm out there collecting urine samples over 24 hours. That's not something I do.
So that's really just what the definition of proteinuria is.
Exactly. Yeah, exactly.
Okay, so what are our clinical features of preeclampsia? So your patient may complain of sudden onset headache, swelling of the hands and face, quite commonly epigastric pain, nausea, vomiting, tenderness in the liver area, so in the right upper quadrant, and also visual disturbance. And this is something to specifically ask for as well. So they may have blurred vision or just be sensitive to light. Also, they may complain of shortness of breath.
Yeah. And so really we should be, I mean, even in patients who aren't having high blood pressure or protein in their urine, you should probably be asking some of these questions and checking for edema at every, you know, certainly in the latter stages of pregnancy, because you don't get preeclampsia in the early stages of pregnancy. So certainly in the second half of pregnancy, you should be asking these questions routinely. Okay.
So severe preeclampsia, this is obviously when we need to take even more notice, is defined as a diastolic blood pressure of at least 110 millimetres of mercury, or a systolic BP of at least 160, with or without the symptoms that we've mentioned, and also biochemical impairments. So this would be if you're doing blood tests, which we'll come on to describe later, actually.
So abnormal biochemistry Sorry, I wrote that. It's just a posh way of saying abnormal blood
Well,
test.
I think it sounds very good, Fran, actually.
Thank you very much. And and virtually any organ system can be affected, can't they? So
Yeah.
you do blood test and it can affect any part of it. So going on from preeclampsia, eclampsia is when preeclampsia evolves into seizures. So it's when the mother has one or more convulsions superimposed on preeclampsia, and obviously that's incredibly serious. So what are the risks? Well, preeclampsia is associated with fetal growth restriction, low birth weight, preterm delivery, stillbirths, small for gestational age, and respiratory distress. So it's
and for the mother as well, the risk of seizures, placental abruption, stroke, and severe bleeding. So it's something that we really do need to pick up on.
Absolutely. And in fact, we were going to say later on, but I'll just mention it here that, although we're very tight at looking after people who have preeclampsia in the UK, I was interested to hear that it's preeclampsia is still the second leading cause of maternal deaths in the UK. Yeah. And it's not just this, is it? So now we're finding as well that women who've had preeclampsia in pregnancy are at increased risk of developing hypertension and heart disease later on in life. So it's not just during that pregnancy, it actually has an ongoing health impact.
Yeah. So who's at risk? That's we need to think about which women we particularly want to think about as having a risk of preeclampsia. So, interestingly, if it's your first pregnancy or your first pregnancy with a new partner, this puts you at increased risks of preeclampsia. Obviously, if you've had preeclampsia before in any pregnancy or eclampsia, the distance between your pregnancies is important. So, if you've had a baby and then not had another one for 10 years, that puts you in a higher risk group. Also, if the distance between your pregnancies is less than 2 years, that again puts you in an increased risk.
Okay.
Are there some others, Fran? I don't want to hear my voice too much.
Oh, okay. So if you're 40 years or more, which is something certainly in Oxfordshire, it's where I live. It's a very wealthy county, lots of women with high-paid jobs, and so we have a lot of women who are giving birth over the age of 40. Again, BMI of 35 or more. So I don't know if in Zambia people calculate the BMI, but that's the ratio of height to weight. So these are obese women, family history of preeclampsia, pre-existing high blood pressure, kidney disease, diabetes, or something called antiphospholipid antibodies, which I'd imagine you won't be testing for in Zambia. It's something I don't test for. It's a it's a clotting disorder, effectively.
It's also more common in multiple pregnancies, so twin or triplet pregnancies. You have a high risk of preeclampsia too.
Yes, and of course, so in the UK, we're having a lot more twin pregnancies because a lot more people are struggling with fertility. So there's a lot more IVF, and because frequently 2 embryos are put back, it means there are a lot more twin pregnancies. So it's an increasing risk here. Yeah.
So interestingly, we still don't really know what causes preeclampsia, although it's thought to begin in the placenta, where there's some sort of problem in the development of the blood vessels. So I think that they're narrowed blood vessels and that they react differently to the hormonal signalling that's going on around pregnancy.
Okay, that's interesting.
So I guess that would indicate why some of the treatments and preventions that we'll come onto later have been thought about, really.
Yeah. And so certainly, previously in the UK, we would scan. So we do an early scan in pregnancy at 11 weeks, and then a later scan at 20 weeks, which is what we call an anomaly scan. So you're looking to make sure that the heart and the lungs and everything is developing normally. But recently, they've just instigated a 36-week scan, which nobody's quite said what it's for. I don't know many if you know much about it, but I think a lot of it was to pick up sort of babies that just aren't developing terribly well at this stage. So it's not necessarily just preeclampsia, because we pick that up during antenatal care. But it's what they do is they're so clever, these ultrasound machines now, and they look at the blood flow, and they can look at the blood flow, and it's coloured and everything. It's really quite incredible, and they can see if there's reduced blood flow to the placenta, which I presume ties into the the risk of somebody then developing preeclampsia, and the risk of the baby becoming low birth weight. Yeah. But on a more basic level, sorry, because we've digressed. So investigations that we're going to do. Well, as with Emma, we're going to dip her urine to check for proteinuria. You also, if there is protein there, you want to check that it's not because she's got a urine infection. So so on our dipsticks that I use in general practice, it has nitrates and leukocytes looking for infection as well, and then in pregnancy what we're particularly looking for is protein and then glucose. So so you're going to check for infection, and if possible you would if you're worried, you'd send them off to hospital for a 24-hour urine collection. If available, you're going to do blood tests, so that's a full blood count, liver test, renal function, and a serum urate. And what you're looking for is sort of the base levels, and then you're repeating them to see if they're altering, and then clotting studies. So
I suppose in the basics that you want to know, if you've only got a limited ability to do blood tests, is with the full blood count, are the platelets falling?
Yeah.
Equally, is the hemoglobin falling? But the platelets are the most interesting thing to you. In this case, if you can do LFTs, well, we're going to come on to talk about HELLP syndrome, which is a severe complication of preeclampsia. In fact, we can talk about it now. So HELLP syndrome, it occurs in about 10 to 20% of women with preeclampsia, and it's a group of symptoms which are characterised by hemolysis, so that will give you anemia, as the red blood cells are destroyed, elevated liver enzymes, and low platelets, which is the acronym for HELLP. That's what it stands for.
Brilliant. Okay.
So your falling platelets is a good sign that something is going on that you need to watch out for, really.
Yeah, but and also just to be mindful that because this threw me a lot, is that there are talking about liver enzymes. So alkaline phosphatase is normally raised in pregnancy, and obviously people are a wee bit more anemic in pregnancy, so that's something that we would normally expect.
So it's looking for a change
exactly
when you've done your baselines, isn't it?
Yep.
So it's looking for that trend rather than a one-off result, in the same way that you've remeasured your blood pressures.
Exactly.
You're looking to see a clearer picture, really.
Yeah, unless of course they're absolutely horrendous values on the first one, in which case you're going to be admitting that person immediately. And then
Thanks,
so sorry, I just so everyone's clear that we're not going to go, oh, they're terrible, we'll do them again.
Just do them again in 2 weeks' time. Yes, no, that's not what you want to be doing.
No. And then so finally, going back to investigations, ideally you would be assessing the fetus, so that would be by using an ultrasound assessment of growth. So in our case, Emma, she's already showing reduced growth, so she is 4 centimetres smaller than we would expect at this stage. And with a good ultrasound machine, they would be measuring the volume of amniotic fluid. They would be doing Dopplers on the umbilical arteries to check out the blood flow.
So if you don't have an ultrasound available, I mean, if you're concerned, basically you need to be referring your patient up to hospital, don't you, for further investigations? Absolutely.
Yeah. And and so the management, which is the next stage, is delivery of the fetus and the placenta is the only cure for preeclampsia. So what you're then deciding is how severe is the preeclampsia, when does this baby need to be delivered.
So it's weighing up the risks of delivering the baby too early, or the risks of the preeclampsia to the mother, I guess.
Yeah, and really that's an obstetrician who should be taking that decision.
Yeah.
That's not something that I would ever be taking in primary care, So all of these people should be seeing an obstetrician for advice on where they go for next. You shouldn't be managing these people in the community unless an obstetrician says that's an appropriate thing to be doing. Yeah.
So just to reiterate that, women should be admitted to hospital for the further investigations if they've got this raised blood pressure of 160 over 100 and with proteinuria, or with any of the other clinical signs and symptoms that we've mentioned.
Yeah. And then, once they've been seen by an obstetrician, so in an ideal world, they will try not to deliver a baby before 34 weeks because we know that outcomes are less good then. So if they feel that the preeclampsia can be managed conservatively because there isn't any evidence of any hematological, any abnormalities on the blood tests, that then obviously they don't need to stay in hospital. And so the first thing we'd be doing in Emma's case, for example, would be starting her on antihypertensive treatment.
So that would generally be started by the obstetrician.
Yes, but it may be. So what would sometimes happen for me would be that I would send the patient up, they would assess them and they would say, well, for now she's fine. We've started her on this medicine. She needs to come to your surgery every 2 days for a blood pressure. And if it goes beyond X, then we'll see her again, so they would be carrying on seeing her, but I would monitor in between, for example.
Okay. Yeah. So which antihypertensives would they be using?
So in pregnancy, we tend to be using labetalol in the UK, and I see that that's on the formulary in Zambia. So that's a good one to use. Or oral nifedipine is another one. And sometimes you need the combination of the two if the blood pressure isn't well enough controlled. And then if the patient is very unwell, you can use IV hydralazine or labetalol. Okay. If you need to get the blood pressure down very quickly. Yeah,
and as you mentioned before, that the treatment for preeclampsia is delivery. So soon after delivery, blood pressure will return to normal unless there's an underlying problem. So you can then stop your antihypertensive medications fairly quickly.
I find it really varies actually between patients. So some patients seem to be able to come off them very, very quickly, and other patients, it can take up to 3 months or so. And normally what I do is get patients to buy a blood pressure machine in the UK and to monitor it and to bring it down slowly. I think so labetalol is typically they take it either 3 or 4 times a day, and in hospital they wake the patients up in the middle of the night to take it. So they're doing it, exactly 6 hourly. And obviously when you have a newborn baby and you're getting very little sleep and you're trying to feed the baby, then setting your alarm to get up to take your labetalol at another time just means you end up more and more sleep deprived. So in my experience, patients are very keen to get the labetalol down, but I try and go as slowly, as slow as sensible. Yeah, absolutely. Yeah.
It's obviously pretty well tolerated, and as you're reducing it, it's okay to be on it when you're breastfeeding.
Absolutely. And so the reason we choose those is because we know that they're safe in pregnancy and in breastfeeding. And then we talked about eclampsia earlier on, and the treatment for eclampsia is magnesium sulfate.
So that's to prevent seizures as an anticonvulsant.
Yes.
Is that right?
Yeah. Okay. So going back to our case, Emma was referred up to hospital, as we discussed, and her blood tests were found to be slightly abnormal. She was started on labetalol, and her blood pressure came down very nicely to 130 over 80. So she was then monitored, and at 36 weeks, the blood test started to become more abnormal, and there were concerns about the baby's growth. So the baby was delivered. Her blood pressure remained stable, and she was discharged on the labetalol, which we talked about, and the baby stayed in special care for 1 week, but was since discharged and doing well.
So one thing I would mention is that babies whose mothers have been on beta blockers do have a risk of hypoglycemia post-delivery.
Thank you.
So that's one thing. Once the baby's been delivered, you need to check the baby's blood sugars and possibly give them a top-up feed if required to ensure that their blood sugars remain within the normal range. It usually doesn't last more than a couple of days.
Okay, yeah. And I think so. I think historically people have kind of gone, oh, we've delivered the baby, everything's fine. But actually, most eclamptic seizures happen postnatally. So these are not people that you should be throwing out of hospital quickly. You need to be looking after them.
And
to make
they
sure
shouldn't be
everything's
delivering
okay.
at home.
No,
Sure.
they absolutely should not be. No.
Yeah.
Yeah. And in fact, I mean, I know we talk about it as a case study, but this is actually based on one of my patients. Yeah.
I wanted to ask you actually, did you ever consider giving her steroids before delivery, or did the obstetricians want her to have steroids in case she needed to be delivered earlier than the 36 weeks?
Gosh, so I can't remember in this case because it is a while ago since this patient, but certainly yes. If you're worried about premature delivery, yes, you would be. And in fact, we had a case on the virtual doctor system recently about that, and it's really important to go and get steroids in for the lung development.
That's right.
It?
So it stimulates the synthesis and release of the surfactant in the baby's lungs. So hopefully, it'll give them an easier ride once they're born.
Right, fantastic. But I think the really sad thing about this case, and this is what we're going on to, is prevention. Is that actually, so this patient in my experience, so she came to me. I started the job, and she came to me when she was pregnant, and unfortunately, it had been missed by both the midwife and the GP that she'd had problems and preeclampsia in her previous pregnancy.
Right.
And so they hadn't been looking after her as well as they should have done, and they hadn't put her on any prevention. So the current feeling is that women with a history of preeclampsia or who are at high risk, so we talked about those risk factors earlier on, you should be considering using a very small dose of aspirin. So it's just 75 milligrams with the idea that this will reduce the risk of preeclampsia.
I was reading that you also sometimes steroids are given to patients with severe preeclampsia or HELLP syndrome too.
Are they?
Yeah, and it can temporarily improve the liver function and the platelet functions. So you can, to try and help prolong a pregnancy, so the baby obviously has more chance to reach a good gestation before you're forced into delivery.
Yeah, fantastic. And so what they've done where I live recently, the obstetricians have produced if I'm honest, it's a slightly laborious check sheet, but it is very, it meant with good intentions, but it is very good because it just runs through all the different things that you should be thinking about. Does this person need to be on low dose aspirin? Does this person need to be on higher dose folic acid, for example? And I'm very happy, and I'm sure they won't mind if I attach this to the podcast just to give people an idea of when you should be thinking about aspirin and a higher dose of folic acid. Yeah, because it certainly it's been really interesting for me because it's not something that historically we did, and so it's a change in the care that I'm giving to patients. So it's useful to share information. Yeah.
And just a final word on the prevention would be that you just need to regularly monitor the blood pressure so that you pick up the hypertension early.
Yeah, and I think just sort of explain to patients that they are at risk of developing high blood pressure so that they're a bit more aware of it. And because I think something like this, in all honesty, I am going to forget which of my patients have preeclampsia. So it's that patient's health. They need to know that that's a risk and bring it to you if they have any symptoms, or just if they come for a checkup, just ask for their blood pressure to be checked as well.
Lovely. Well, thank you very much for what am I saying? Thank you very much for that, Fran. That's really interesting. And if you've got any more ideas of podcasts you'd like, please let us know.
Brilliant. Thank you very much and goodbye.
Bye.